Hello, my name is Dr. Zach Winkleman. I am a clinical assistant professor at University of South Carolina, and I'm the clinical education coordinator for our post-professional advanced athletic training program. Today, I'll be discussing emergency preparedness for mental health conditions. I just want to start out by saying thank you to MAATA for having me in this virtual space to do this presentation, and I'm looking forward to it. I have no relevant disclosures or conflicts of interest relative to the material. The purpose of our presentation today is to provide you an overview of some mental health conditions, really exploring some of the signs and symptoms and things that lead to suicidal risk. And then we'll discuss about how to create and design a policy relative to emergency preparedness for screening, emergency care, and some of our awareness and recognition needed for mental health emergencies. And finally, we're going to describe some support procedures relative to athletic training specific to suicide and mental health conditions. Now, it's important to start off by reminding everyone that's listening to this has mental health, and that we need to start reviewing and talking about mental health in the same aspect that we have done for physical health for years. I've been a certified athletic trainer for 7 years now, and I've seen the conversation drastically change in that time about how we discuss this relative to sports medicine. And that's an improvement on our part, but we have to continue creating a better, safer environment for individuals to do so, especially in our college and university settings where there's such a stigma and discrimination linked back to mental and behavioral health. It's also important that we remember that 1 in 5 people have mental health illness, and so they have a diagnosable condition or suffer from a debilitating disease that impacts their activities of daily living. Now, that does not make you immune to it. Just because you have mental health or you do not currently suffer from a mental illness does not mean you cannot develop one. And so it's important to realize that this is a fluid condition that has periods of relapse, but also has periods that people are symptom-free, but no one is immune to developing it. Now, the bigger aspect here that I'm going to discuss is all about how mental health and mental illness link back to suicide. 90% of individuals that die by suicide have a mental health illness. Now, contrast back that 98% of people that have a mental illness do not die by suicide. So if you use that data, 2% of people that have a mental illness die by suicide. So it's important that we look at this, that not all mental health conditions lead to death by suicide, but individuals that 90% of people that die of suicide have some type of mental illness. So we have to understand that there is a link, but from the suicide risk, but it doesn't mean that mental health conditions lead to suicide. And I think that's important for us to remember. The large semicolon on the other side is to remind us that, Project Semicolon is a suicide awareness project that reminds us that, sentences keep going, that a period ends a sentence and that marks the end of a person's life. But if we start to think about suicide and mental health using semicolons, that it's just a change in someone's time and keep that sentence going, that we are able to do so in a way that encourages people to remove themselves from suicide risk and seek out help-seeking behaviors to improve their life. So some of our background relative to mental health is that many of the risk factors that are linked back to mental illness are contextual, meaning that it's hard to describe what one specific person or disease may look like. So demographics, their social and cultural background, the environment where people grow up and live, all of these things impact how an individual's mental health may be affected. Now, the mental health field has been plagued by disparities, meaning access and availability of services for a long period of time, and that these disparities are often linked back to other contextual factors such as diversity, age, and gender, which we'll discuss in a little bit more detail. And all of these things link back to this idea of patient-centered care and the social determinants of health. So if we explore how the social determinants of health have been kind of described, we see that the social, environmental, and economic structures are things that impact these disparities related to mental health. So for example, a stigma, discrimination, societally and community-based are things that discourage reporting and seeking behaviors. Economic structures in terms of stability and poverty are often linked back to mental health disparities. And finally, the environment, including exclusion and in terms of people in their neighborhoods and environment around them not wanting to associate with individuals that have mental health concerns, are all disparities that impact someone's ability to get better or the ability to get the help that they need. So where do we see this most in our society? So think back to groups that are affected. So diversity, age, gender, and some specific backgrounds. And where we see this the most is biracial individuals, so the top picture, are most likely to report mental illness. Depression is highest in Hispanics. We see that PTSD is the highest in our military individuals. American Indians have the highest rate of alcohol dependence. White individuals in the United States are the most likely to die by suicide. And finally, religious discrimination, specifically that of Muslims, are often associated with anxiety and suicidal or subclinical paranoia. Meaning that their religion has changed their ability to interact with society in the United States. So we're able to see that no one is immune, regardless of race, ethnicity, age, gender. All of these are things that affect mental health. Is all the things that affect each of these individuals. Specifically, if we look at this one study that was done relative to the amount of days spent depressed and anxious, we're able to see that gender also has an influence, that individuals who are heterosexual or homosexual, meaning gay or lesbian, often spend about 4 days depressed and 8 days anxious in a month time span. Now, if we take that data and extrapolate it back to individuals that are bisexual or transgender, we're able to see that that number goes up, that an individual that is transgender spends about double the time depressed, so 8 days a month, and 11 days anxious. And so this data tells us that gender, or someone's sexual orientation, being bisexual, which is the middle data, does have an influence on someone's likelihood to suffer from a mental illness. Now, that extrapolated with age also influences some of our outcomes relative to suicide risk. So this was a study done in 2015 that explored risk behaviors for youth individuals that were sexual minorities, meaning lesbian, gay, or bisexual. And what this found is that they were more likely, they being the sexual minority individuals, were more likely to have attempted suicide in the past 12 months. If we look at that data over time, we're also able to see that sexual minorities often planned their suicide almost 3 times more likely. So from 11.9% to 34.9%, just depending on someone's sexual orientation. And so this is a really important data that we have to be mindful that a safe space and inclusive patient care often dictates our ability to provide mental health care. And so if you're unable to do that in terms of safe space in your athletic training facility, we often do not create an environment that is supportive. And when we have an unsupportive environment, the risk of attempted suicide is 20% greater as compared to that of supportive environments. So as an athletic trainer, we need to be implementing safe space training and creating these environments that promote gender identity, gender discussions, and sexuality discussions so that people are able to feel that their athletic trainer is supportive, and that it's not just about saying, I treat all patients equally, that we have to be mindful that patients do require different care depending on their age, gender, and diversity background. Now, if we take some of this information and identify it back to suicide, which is going to be the kind of main focus of my presentation, is that we see that specifically individuals that are depressed suffer from ADHD or eating and feeding disorders, and then those that have been diagnosed with a mental health disorder, such as schizophrenia or bipolar disorder, are likely to have conditions that put them most at risk or lead to suicide. From an athletic training perspective, we're also able to see that catastrophic injuries, these can be things like car accidents, season-ending injuries, traumatic brain injuries like concussions, all of these catastrophic injuries which really change the contextual factors for a person's daily living can also lead to suicide risk. And so we have to be mindful that a concussion may lead to depression, which may lead to suicide, and that we have to make those links there, that we get the people the resources they need, not just to return to learn or return to play, but return to the mental health that they once had before their mental illness developed. And as I said, suicide has been a word that people just didn't want to talk about. And, in athletic training, we've done a really good job to focus on domain 1 and 2 in our field, which is immediate emergency care and injury and illness prevention. And what we've done through that is decrease the risk of exertional heat stroke by implementing gold standards. We have identified position statements relative to diabetes and sudden death and sickle cell and rhabdomyolysis, that we have really focused on improving the patient care and decreasing the risk of things that we know lead to death. I want the same thing to be true for that of suicide. Mental health as a field, as a larger behavioral health context, has so many conditions. Now, specifically, suicide is the second leading cause of death for individuals 15 to 24 in the United States. And this is the largest patient demographic that we have in athletic training for our traditional settings. So if we explore high school and college individuals, they typically are between 14 to 23, and this is our demographic. We have to focus the same amount of efforts to prevent death in the same way for leading causes like exertional heat stroke and cardiac abnormalities, the same way when we start to discuss that. We have to focus on suicide in that same behavior. And that's what this presentation hopefully will get at. So, and to do so, we have to be prepared. To do preparedness, we need to be mindful of the situation that's presented to us. So one is a mental health crisis and one is a mental health emergency. Now, they both sound bad, and that's it's because we both need to be acting on these, but you need to act in a different manner. A mental health crisis means that someone is in a point that is in distress, that they're unable to be calmed, and that it creates a situation, but it's non-life threatening. So they may be talking about suicide, they may be exhibiting behaviors that don't help themselves, so they may have been prescribed some type of antipsychotic medication, but not taking it. They may have a feeding or eating disorder that is causing them disturbances and behavioral distress themselves. All of these things are non-life threatening in that moment. Over time could become life threatening, but in that moment is a crisis, not an emergency. The difference for a mental health emergency is when we have a life-threatening situation. This is when individuals are acting on a suicidal threat, are homicidal, or have threatening behaviors to others, or needing immediate medical attention for self-induced harm. So these instances are when we have to influence or create our emergency action plans. We have to act on that moment. A crisis needs to be handled in a different manner in terms of what we do in terms of referral and treatment. And this is where we get back to the role of the athletic trainer. So for some time now, I've heard that, an athletic trainer may not have a role in this, that this is outside of our scope. There are trained individuals. And I agree, there are some individuals that are better trained in mental health, and that includes social workers, mental health counselors, psychologists and psychiatrists. All these individuals have a role. But in the terms of interprofessional practice and collaborative practice, we have to understand our role as well. That in the direct access to patient care, seeing these individuals typically on a daily basis, that we often know so much more about them that another individual, such as a counselor, may not have that inside information, if you will, to their daily life. So we have a role in awareness, we have a role in recognition, but we also have a job to do in referral. But I want to encourage everyone to explore other assets that we have as athletic trainers. We can create and influence individuals to create a wellness promotion plan relative to mental health. Now, the focus on this is emergency preparedness, but I want to encourage you to create an athletic training facility that promotes mindfulness, meditation, guided imagery, yoga, use of essential oils. All of these are evidence-based strategies that we know help to decrease anxiety, stress, and depression. If we know those things work and we know our athletic populations are at high risk for those, why are we not doing them? We can do those and share those with our student athletes and our patient panels to encourage that idea that we want to reduce this injury prevention or illness prevention. Now, it doesn't mean we're treating their depression or anxiety. We're trying to reduce the effect of those the environment on them. And that's what this mental health card does on the right. So this is from the NATA News. It's produced by AT's Care Committee. And it's a color-coded guideline system that allows you to see where someone's at. So if someone is having alcohol abuse, that is under a raised awareness, a green area. That means you may want to get them some help. But taking action. So if someone is attempting suicide, if they're attempting to harm another individual, if they have extreme risk-taking behaviors, this is when you want to, these aggressive behaviors are when we want to make sure that we get immediate attention and referral using our emergency action plans. So you have to have an emergency action plan in place to be able to do that. So this begins with awareness. So our protective factors. These are the things that individuals may have that we are aware of that reduce or mitigate the risk relative to suicide. But we also know if these things are not available, it increases the risk. So the first is effective clinical care. Do they have care for mental health care planning, for substance abuse, and for physical care? Access. Do they have easy access to interventions and self-help programs located in their community or on their campus? Connectedness. Do they have a family and social support system, whether that be their team, coaches, roommates, or yourself as the athletic trainer? Resolution. We have some data that supports that student athletes have a high risk for anger. And we know that anger relative to internal or external anger changes how someone is able to influence. So do we promote and encourage conflict resolution, problem solving, and coming up with ideas that are non-combative or non-targeting ways to deal with bad situations? And finally, we need to look at this from a holistic lens that often cultural or religious beliefs often discourage suicide. So that an individual that is Hispanic, culturally, say Puerto Rican or Colombian culture, discourages suicide because that person has a cultural or familial factor that says that we need you to help take care of the family, and that discourages suicide behaviors. And the same is true for religion, where we see that the religion itself discourages suicide risk by encouraging self-preservation. I'm a large proponent of words matter, that we have to stop talking about mental illness as an adjective, that the individual, the illness that we have can't be a conversation starter. What this means is, as an athletic trainer, we have to stop saying things like, I'm going to kill myself if I'm going to have to sit through this meeting today, or just shoot me and we have practice again tonight, or I'm so OCD, I got to put all of the water bottles back just the same way. Now, all these things may be common, or you may feel that way in the moment, but those words matter, and we have to stop saying those things out loud, especially in our patient, while we're doing patient care. This does not create a supportive environment, and it makes it seem that suicide and other mental illnesses like OCD are just another adjective. They're not a condition. So please be mindful of the words you're choosing to use while you're doing your patient care. Now, some other words that I think are important to define or to discuss are relative to suicide. So previously, the nomenclature or how people discussed suicide in conversation was that someone committed suicide. And recently there's been an emphasis that someone doesn't commit something. You don't commit cancer. You have cancer, or you died of cancer. You didn't commit cancer if someone happens to die from it. And so we want to be encouraged that suicide is discussed in the same manner as some of our lethal conditions that we experience. So you wouldn't say someone committed an exertional heat stroke. You would say someone died from exertional heat stroke, and that same language has to be true, that someone died by suicide. So be mindful of that language. Now, when we're talking about a suicide attempt, that is a sequence of behaviors when at the time had an expected outcome that would lead to the one's own death, meaning that if I did X, Y, and Z, this will lead to my death. The time of initiation is the period when the method that they have come up with or they've completed suicide. And the lethality is how lethal that attempt or that plan is relative to what they're trying to do. So for example, if they are trying to take their own life or end their own life using an attempt that is non-lethal, meaning I'm going to sit in the hot sun and see what will happen. That is a low lethality or non-lethal attempt versus I'm going to use a firearm and shoot myself. That is a high lethality. And so we're able to see that a plan typically is determined by the lethality there. Now, awareness also comes from the idea of prevention, that we need to encourage individuals to use this hotline. So 1-800-273-8255. I'm going to say it one more time, 1-800-273-8255. Save it in your phone and encourage people to use this hotline as a resource. Post it in your athletic training facility, share it in your pre-participation paperwork, and let people know that this is out there. It was created in 2005, so it's only about 15 years old. It's free to call and is staffed by 163 local crisis centers across the United States. Most recently, the United States government has seen that the number is long. It's hard to remember. A 1-800 number is not something that's easy to remember. If your house is burning down, you would hate to have to figure out how to call 1-800 something to get to your local fire department to get you help. And so what they did in the United States was created 911. And the same's now been true for mental health and specifically suicide risk. And that 988 will be the new number that is quicker and shorter for people to remember to get access to care. And this was just recently passed at the end of 2019. And this was really driven because 2.2 million people in 2018 called. And they identified from the research that most individuals who make a severe but non-fatal suicide attempt never attempt again and have a 93% survival rate. What that means is that people that often attempt a suicide but it is non-fatal, meaning they did not die from it, never attempt again. Get people the help they need. This picture on the right is from the University of South Carolina at Williams-Brice Stadium, where our football team plays. Our starting quarterback this past year, Ryan Helinski, his brother died by suicide while he was at Washington State University as a football player there. His name was Tyler. Their family has created Helinski's Hope. And at the start of the third quarter, they hold up a number 3, which was Tyler Helinski's number. And this became kind of a nationwide phenomenon, especially in this SEC this past year, that at the beginning of the third quarter, they would start off by putting up the mental health hotline number. People would hold up 3s, and it just became something that everyone started the discussion about, specifically around sports. And it was wonderful to see how Helinski's Hope really tried to encourage the conversation to begin. Next, we need to recognize. Recognizing is about signs, symptoms, and what we're looking for. So what I'm going to read here is what's called DSM-5. DSM-5 is our mental and behavioral health kind of handbook, if you will, which is typically uncommon for athletic trainers to study it or look at it, but the true definition of mental and behavioral health concerns come out of this language. So non-suicidal self-injury means that in the last year, patients have on 5+ days engaged in intentional self-inflicted damage to the surface of their body. So that means in the last year that an individual at least 5 days or more has tried to cut themselves. They've tried to inflict pain or bruising. They've tried to hit themselves with objects. That they try to do something to their body that was non-suicidal, but it was self-injury. Now, typically, these methods are cutting, burning, stabbing, rubbing, and we see that there's often a connotation that these behaviors are a gateway, if you will, to suicide. And I think it's important to realize that non-suicidal self-injury is not a typical plan for suicide, that these behaviors are performed often as a relief from negative feelings to modify their cognitive state, to resolve some type of difficulty going on in their life and induce a positive feeling rather than remove the life for themselves. So be mindful that a self-injury such as cutting and stabbing and burning does not typically mean someone wants to end their life. They're trying to get in a positive state that doing the self-injury makes them feel good. This is a predictor of substance use or misuse, and so individuals using alcohol or drugs, but there is the likelihood of suicide intent has been associated with self-harm, but self-harm itself does not lead to suicide. So please be mindful that there is an intent here that's driven, but it does not mean that if someone cuts that they want to end their life. Now, suicide itself is the 10th leading cause of death in the United States overall. It typically has about 45,000 Americans die by suicide every year, and that and 25 is the estimated number of attempts for every one suicide. So while we know that 45,000 people die by suicide, which is the number of people that are athletic trainers in the NATA, that means that every athletic trainer in the United States would die. Now, for those individuals, 25 other people had attempted suicide, but had a non-lethal attempt, or they had an incomplete suicide attempt. And so it's important to know that this is affecting more people than the 44,000 that is listed here. Specifically to athletic training, the NCAA male athletes have a higher rate of suicide compared with female athletes, and more specifically, football athletes appear to be at the greatest risk. Suicide has represented 7.3% of all causes of mortality among NCAA student athletes. This makes it the 3rd leading cause of death specifically for NCAA student athletes. So if we take the data that the age group 15 to 24 is a 2nd leading cause of death for suicide, and that suicide specific to NCAA athletes is the 3rd leading cause of death, we really need to be focusing on how we can reduce or prevent this from occurring. Finally, 13.6% of students planned about how they would attempt suicide in the last 12 months. And we're able to see that this is higher in females, so 6.6% higher, that males are more instinctive or just happen to do it, where females are typically more of a planner. And that comes back to personality research. But it is able to see that almost 13.6% of students in high school are still planning or thinking about their suicide attempt. So we have to understand that males, specifically at football, anybody at NCAA student athlete, and that females in high school, all of these are risk factor populations for suicide. Now, this is the condition. So suicide itself is not a condition linked back to the DSM-5 criteria, but suicidal behavior disorder is, and these are the 4 criteria. So within the last 2 years, the individual has made an attempt. The act was not initiated during a state of delirium or confusion. The act was not undertaken solely for a political or religious objective, and that this was not preparation for suicide attempt or suicidal ideation. So that it's important to recognize that these criteria have to be met for someone to have suicidal behavior disorder, meaning that they can get certain counseling, therapy, and interventions necessary for their risk. The issue is that we often don't get to this point, that someone's suicide attempt may be their first, and it may be a completed suicide, meaning that they cannot get the help they need to be diagnosed with suicidal behavior disorder, which is why the data is really lacking right there in the mental health field relative to how prevalent this condition really is. Now, suicidal behavior disorder is a manifestation, is a suicide attempt or the intent to die. So the idea here is that the individuals that are diagnosed with this have an intent to end their life. Now, the degree of intent can be challenging to mark or figure out, but the risk typically means that individuals have selected a time or place, that they've thought about minimizing their resources that they need in an interruption by other people. Individuals that often suffer from SBD have chronic pain or chronic illnesses. Their mental state at the time of the act may be acutely agitated or quickly angered, not figuring out how to manage their conflict resolution at that time. And then they may have recently stopped or discontinued the use of mood stabilizers such as lithium or antipsychotic medication. All four of these things are things that would increase the intent to die or the risk that someone may be completing a suicide attempt. Now, when we go back to look at the SBD criteria, it's typically characterized in terms of these three areas. So the violence, is it a non-violent or violent plan? A violent plan would be like a gunshot wound or jumping. A non-violent plan would be like an overdose. Lethality, it's either a high or low attempt, as we discussed before. A high lethality requires hospitalization beyond a visit to the emergency department. A low lethality is typically due to a lack of knowledge in the top or the selection that they've used. So for example, a low lethality using an overdose of illegal substances, they may not have used the correct combination of drugs or enough of the drug itself to actually induce death for themselves. And so the lethality may be low, but that's typically due to a lack of knowledge in the topic. And then the planning. High degree of planning, as we saw in our high school female students, is linked back to the medical outcome of the suicide attempt, meaning that what all went into it and was it the attempt successful? And then the plan, the impulsiveness. So this is usually low intentionality or this idea that they were acting in a state of acute agitation. Now, when we're thinking about suicidality or this thought that someone might be thinking about or ideation of suicide, that these are the main warning signs. So a history of substance abuse, a previous suicide attempt. They may be having a current physical disability such as athletic related injury. They may have lost a family friend or family member recently. They may be being bullied at their school, and this is something that is outside of the scope of athletic training, but then does create a conversation for us to have relative to the role of sport. We're able to see that sport has a lot of positive aspects, but in the literature for youth, there's also a bullying behavior from coaches and peers that are often associated with sport that may make people suicidal or have suicidal ideation relative to playing sports. Relationship problems, especially for our teenagers, and access to harmful means. And then for individuals that you may see warning signs or symptoms of, your next thing you want to be mindful of is preparatory acts. When we're talking about preparatory acts, these are things that people will do lead up to a suicide attempt. So they may sell some of their valuables or sell things that mean a lot to them so they don't have to worry about people having to get rid of their things once they're gone. They may be exhibiting aggressive behaviors, discussing comments about harming themselves, not interacting with others and socially withdrawing to reduce the relationships that they may be having. Writing about death or talking about death, not suicide itself, but just death in general. Increase alcohol or drug use. They may be collecting pills. So as an athletic trainer, if you hand out over-the-counters or medication, being mindful and watching someone actually take the medicine and not just storing it or collecting it. Buying a gun and then writing a suicide note. So either handwritten or typed, and seeing that people put thought process and time as a preparation act here. One of the biggest things that I would recommend is listening to our patients, that when they're sitting on that treatment table, we need to be mindful of the words that they're saying. This is not an end-all be-all list here, and this is not a necessarily evidence-based list, but these are comments relative to some statements you may hear for people that are experiencing suicidal ideation, such as, I just want to sleep forever. I want to take the focus away from everything else. You'll be sorry when I'm gone. I won't be a problem much longer. There's no way out. All of these are warning signs, risk factors, and cries for help to an individual that we often may respond back to this and say, you'll be fine, or you don't mean that. In that moment, we do need to engage with that person, not dismiss their conversation, and be mindful of the words that they have chose to say to us because they meant it, and they are using this as a way for us to start the conversation. This is a picture of the Golden Gate Bridge, and so the idea here is that means and methods are often discussed about what do we have access to, and what do individuals have access to, and what would someone do if they are experiencing suicidal ideation. Now, our job as an athletic trainer is not to remove these things, but just be mindful of the means and methods that people may use most commonly to end their life using suicide. So these include things like cutting, dehydration, purposefully contracting a disease such as AIDS, drowning themselves, electrocution, hanging. Hanging is most common in rural areas due to access to not necessarily a lot of resources. So using a rope or some type of higher platform like a tree. These are things that are common in rural areas. Immolation, indirect suicide. This is like enlisting in the military, becoming a cop. So doing something because they know that the risk of death goes up. Jumping from a height. We often associate suicide in the United States with jumping from something like the Golden Gate Bridge, but it's actually the least common method in the United States. Using a poison such as a drug overdose, carbon monoxide, sitting in a locked garage, suicide attacks, so like 9/11 and Virginia Tech, vehicular impact, so sitting or parking in front of a moving train. And the most common factor in the United States is firearm and gun use at 50.5%. So out of all these other means, half of them are due to firearm or gun use. Now, in the United States, we're able to see that there's no effective approach to reduce suicidal attempts altogether on a large scale. But we are able to see that policy has an effect on suicidal means and methods. Places that have stricter firearm and gun policies, we're able to see that they have a lower suicidal attempt and completed suicide data relative to that. And that places that have a higher or more loose firearm policy in terms of no background checks, easy access to guns, often have a higher link to suicidal attempts. Now, it is important to note that their gun ownership has no link to suicide itself, or to mental health itself. So there is a link between guns and suicide, but just because someone has a gun does not make them make their mental health lower. And that we need to be mindful that people that may be suffering from mental illness may have easy access to guns and firearms, and that this policy here does change the likelihood that someone can use it for as a mean or method. And so there's two really good studies in the past couple of years that are out there that shows that stricter gun policies do reduce the risk of suicide in areas that have pretty lax firearm policies. So be mindful about that as we try to combat this on a community or population level health prevention mechanism. Treatment is the thing that we need to do is alleviate the impulse of suicide. So to do that, we have to improve the coping mechanisms. So to improve coping mechanisms, we need to really think about conflict resolution, non-violent ways to deal with problems, and really trying to make people understand how to handle acute agitation. Whether that be from a new diagnosis of an injury or illness, removal from sport participation, or just simply being mad or upset about something happening. So for us as an athletic trainer, it's about referring. But before we get to that point, it's about the installation of hope. I think as an athletic trainer, this is in our scope of practice, and that we can encourage people that there is hope, that letting people know they are not alone, but avoiding the things in statements like, I understand what you're going through, or it's all going to be okay. Those instances and those comments are not the treatment that they need to hear. You don't understand what they're going through. Even if you've had mental health illness or a suicide attempt yourself, everyone's experience is different. What you need to do is get them the help, or help them find the reasons to continue living. And to do so, we have to refer. So to make that referral, we have to know how to start the conversation. So say someone's sitting on your athletic training table and they say, it's all going to be over soon. You won't have to worry about me much longer. And then we start the conversation by saying, can you tell me what's troubling you? How's life going? And then if people start discussing instances there, we need to be mindful about the words, that we're not just hearing them, but we're listening to them. And specifically when we hear about or see specific behaviors, say that someone slammed a door and got easily agitated, or they were selling off their property or collecting their pills, that we use those specific incidents to create the conversation. So, hey, Zach, I noticed that you didn't take your medication today, which has caused me to become concerned for you. Can you tell me a little bit more about why you didn't take your medicine? So you're really linking back a specific behavior and asking them to share more about or tell you more about that specific incident. Now, the difficult conversation comes when someone says things that may get you worried. And these are questions that I've done both as an athletic trainer and as an educator, and that this is not just for clinical care. This is for educators that are listening too, that we have to be mindful that our students are also suffering or struggling, and that we need to have this conversation with them as well. In that moment, you have to assume that everyone's telling the truth. You cannot put words and promises on linked back to these, where you say, I need you to make sure you tell me the truth, or don't lie to me. Those instances make a breakdown of relationship in terms of that communication. But the 4 questions I would encourage, and the literature encourages us to ask, is, are you having thoughts of harming yourself? If you're comfortable, you can say, are you having thoughts of suicide? If you don't want to use that word, harming yourself may be a good method or means to get comfortable with it. Have you thought about how you would do it, how you would harm yourself? Do you have access to things that you want to use to harm yourself? And have you thought about when you would do it? Now, if they answer no to one of these things, so are you having thought about harming yourself, and your patient responds no, there may not be a need to ask the next 3 questions. But if a person answers yes to that first one, you need to go through all of those instances, because this comes back to the planning, the lethality, the thought process that's going in, and the violent and non-violent behaviors that really change from a crisis to an emergency for you. Now, your job is not analyze the plan, the access to the resources, when they're going to do it. The job is for you is to get that information, have the conversation, and move forward. Now, I found myself when I was discussing this with someone the first time, that I said, promise me that if any of these things change, that you'll tell me. And now, because they told me they were not having thoughts of harming themselves. Now, I encourage you to create that relationship with someone, but don't place promises on the relationship. It is too burdensome for you and that person to feel like they have to contact or reach you. And that may not be the best person they need to reach at that moment. And also, if they end up having a suicide attempt or completed suicide, don't have that burden on yourself that you have made that promise to someone and they let you down, or they didn't follow through with what they promised. So be mindful about your words and your actions here in terms of getting the people the help. Now, if any responds yes to any of these comments, you have to be mindful about what they say. At this moment, you cannot leave the person alone. Don't try to determine the lethality or the seriousness of what they said. If they have said it, they mean it, and they're telling the truth. Don't assume that the person is trying to just get attention or get out of doing something like practice for the day. Suicide is not selfish, and the words that they've shared with you are meaningful. So act on them and help them to remove the potentially dangerous situation that they're in. What you need to do is make an immediate referral for anyone that answers yes to the previous 4 questions. You've now started your mental health emergency policy. So relative to your policy, you would need to be mindful of counseling centers or local hospital emergency rooms or emergency departments to get people the access they need. So you have to know where your resources are and what to do. Now, if you did this through telemedicine or a phone call, text message, it's going to be hard to help them at that moment, right? Because they technically are alone, even though you're virtually together. So you have to be mindful about getting someone in the same room as them or getting them the help that they need in that moment. So this could be a wellness check using your local police or campus safety, and having someone go over there and check on them while you're still on the phone or communicating with them. So for most of our policies, it's to get them to a counseling center for a screen as soon as possible. If someone doesn't have the ability to do that, you can go to another counseling center. But if not, then that means you need to refer them to an emergency room. Now, if someone says that they do not have suicidal ideation, but struggling with anxiety and depression, or that they are having non-life-threatening thoughts of suicide, but don't have a plan, don't have thoughts to harm themselves in the current moment, that still doesn't mean you shouldn't refer them. You still need to send them out to a counseling center, but it could be a non-emergency referral. So this is a crisis referral, not emergency referral. Some things you can do also if you are concerned about what to do is this is the National Suicide Prevention Lifeline's risk assessment. So you could do this yourself or have a patient do it if you feel comfortable, but essentially listening to their answers while you're doing it. And so say a person calls you on telemedicine or they report these things to you and you're not with them, you can get the components below. So did they say they feel hopeless or helpless, they're using substances, that they're currently intoxicated or drunk, that that they don't know the method that they are thinking about, they are trapped. You're able to see where they kind of fit into this suicidal risk. So they have a desire, are they capable, and do they have the intent? So the intent column, are they currently in progress? Do they have the plans to kill themselves or homicidal behaviors to kill someone else? Have they had the preparatory acts of collecting the pills, getting their means, writing their note, and they have expressed intent to die? If those things are true, this is an immediate referral. So in that meantime, while we're doing this, we need to be thinking about social support systems, getting immediate support lines, suicide hotlines, things about positive reinforcement and sense of purpose, instilling that sense of hope for the individual. And that these ideas will help us in terms of the assessment. Now, there's some other outcome measures like the SAFE-T and the Columbia Suicide Severe Rating Scale, which may be helpful if you like to use outcome measures to assess risk. But for my clinical practice and my recommendation back to you is really use those 4 guiding questions to help you to understand if you need to implement your emergency action plan relative to suicide. And finally, the part about here with referral is that, you know, if an individual does die by suicide, we can't stop there. And as athletic trainers, we need to be mindful about our work and how we handle this. This is a screenshot that I pulled from a social media site that someone posted where they shared their story about a patient that died by suicide. There were no signs, there was no explanation, they were in shock and visited most often to them, and really the stuff was just no big deal. And they were asking, how do you prepare yourself to cope with this? And we'll never know why. And I think what we need to be mindful of here is that you have to take care of yourself, realize that it's not your fault, and that it's okay to grieve. And as athletic trainers, that as we lose a patient by suicide, that we need to be mindful that the same thing is true. We can't sit there and reflect so much on the risk factors, or what did I miss? How did I go wrong? Where did it, what was the patient saying the whole time? Avoid that over-involvement in there. Collaborate with other healthcare providers and really do yourself justice to understand that suicide is multifactorial, that we may not see the whole picture, that someone may be happy while they're at school, but often unhappy when they get home if they have a tough living situation, and that you may not see the patient in the whole process. So this is why creating a conversation and taking care of yourself is so important, but also reaching out to individuals to help through that situation after it is over, and understanding that we now have a role to help all the other patients that may be affected by this. So helping them with grief counseling and critical incident management relative to the experience that they had as well. Finally, I would like to discuss how to actually be prepared. So implementing policy to practice. So if we look at the NATA's position statement on emergency action planning, we're able to see that you need to have written EAPs shared and developed in consultation with your local providers. That's EMS, medical directors, whoever that may be. Then training of all your stakeholders in key first aid steps, reviewing, rehearsing annually or after implementation, and then incorporating legal counsel. These 4 guiding principles from the emergency planning and athletics position statement, I believe, are still stand true for our suicide emergency action planning. We need to have an EAP that's designed and developed in consultation with the psychologist, your school counselors, your counseling program, and the local hospital. You need to understand who, what resources, and how they are going to be implemented. Say your counseling center closes at 5 p.m. and someone is displaying suicidal risk, but the local hospital doesn't have a behavioral health unit, that you may need to contact your campus police to take or help someone in that moment. The training of your stakeholders, there's key first aid steps, and there's a great program that's going around called Mental Health First Aid. MAATA is also offering that as part of this conference, and if it's not provided in this moment, please seek it out. But considering that first aid like CPR, wound healing, AED use, and the same steps in terms of mental health first aid. Those 4 questions are not healthcare provider specific, and encouraging people to know that if a patient or a student athlete for a coach is exhibiting any yeses to those 4 questions, that they are able to know what the next steps are in terms of implementing their EAP. We need to review and rehearse our emergency action plans. You know, we often go over spine boarding, splinting, maybe exertional heat stroke with cold water immersion, and the same needs to be true when we review and rehearse an EAP relative to suicide or a mental health emergency like homicidal behavior, that we need to know what steps are going to happen. So without preparation, try to do a run through. Let everyone know in the next week or 2, we're going to rehearse our EAP. You'll, if you can create a patient scenario or a mock case, implement it, see if people answer the phone, see what happens, see how it goes, and contact your school counselors, bring someone over there, really implement it to see, do these things actually work if we try it? And then after doing so, sit down, debrief, and discuss the policy changes that are necessary. Now, after implementation of an EAP, say someone has suicidal risk and you implement it, probably want to debrief as a group first, but then sit down and talk about how we need to review the policy to make changes to really improve patient safety and comfort during that experience. So what was the policy? What was the things that we need to be mindful of, and how should we revise it to make sure it's 1, evidence-based, but 2, up to date for our current facilities? So for instance, if your counseling department is under construction and you can't get access to them over there from your athletics facilities, how are you really going to do that? If you're going to say, I'm going to walk someone over there, but it's a 45-minute walk across multiple bridges, and the person says that, you know, my plan was to jump off of a bridge, and then you walk them across a bridge to the counseling center. That doesn't seem to be a helpful use of the emergency action plan. So we have to be mindful about the questions that we ask, the data that we get, and making sure people don't have access to means and they're never left alone. But how do you do that without reviewing, rehearsing, and practicing it? Finally, whenever you create a policy, you always should incorporate your legal counsel at your school. If you don't have one at your school itself or your clinic, reach out to the school district and ask someone to review the policy to make sure that it crosses all the T's and dots the I's relative to implementation. This is key to make sure that you're protecting yourself moving forward. So policy development, I believe, needs to require preparedness for the athletic trainer. So they have to understand how to identify, refer, which means that you may need to provide training to everyone on staff. If someone's going to implement a policy that requires them to identify and refer suicidal risk or behavioral health conditions, they need to have training or education relative to those things that they're looking for. The biggest thing I want you to be mindful of here is that you're not responding to an incident. If someone comes into you and says, you know, I'm thinking about taking my own life, that you're not responding to that incident. That a policy, when you're writing it, is meant to prepare to prevent things from happening. That you don't want to have someone that is now have died by suicide thinking about what I should have done. What did we have in place? Why didn't we have something in place to help that person? Think about the stakeholders you may have. Some coaches oftentimes want to be that gatekeeper to all of the things that have to deal with a patient. And they often assume student athletes are fine, that they don't have issues or concerns going on, and that they're healthy. And that coaches need to also remember that they're not just student athletes, they're human beings. And the same things still exist there, that they need to be mindful of policies relative to mental health and helping to implement those moving forward. We also have to be mindful that these are typically young people, that they are typically 15 to 24 years old. They're dealing with school, relationships, bullies, and those pressures often coincide at the same time with athletic performance. And those things together may create the perfect storm for suicidal ideation. The Interassociation Task Force relative to mental health said that #1 step is a policy for screening. Now, there's a 9-question screening document in the pre-participation position statement that I would encourage you to implement. If it says yes to any of those 9 questions, it's an immediate referral to a mental health counselor or the next step of whatever your school may have in place. The issue with that is some of the questions are about fatigue and lack of sleep. And people would said, I don't want to refer everyone that says yes to this. Now we have to understand that fatigue and lack of sleep is a multifactorial approach as well. But those are risk factors if people aren't sleeping and getting the stuff that they need there, that they may develop a mental health condition and act on those things out of acute agitation during sleep deprivation. So the first step to do is finding a screening. And that policy needs to include screening. It also needs to create an emergency action plan. It needs to include referral and recognition. But we also need to make sure this is happening now. This is a wonderful time during COVID-19, during the pandemic, to sit down and revise and implement policy. We want to be doing this and creating a policy now, rather than say 4 a.m. in the morning and you get a phone call from somebody that says, you know, the student athlete at our school is having suicidal thoughts. That's not the time to figure out the best approach to handle this situation. Often those times we need to have the collaboration necessary to understand that during school, this is the person to call. After school and after hours, these are the people to call, because school counselors may not be available at all times. So having a in-school and out-of-school policy is also a really great recommendation. We need to have those resources available to determine what's the best option. So is the best option the hospital emergency department? Is it a psychiatric emergency care? Is it calling the local police or campus safety? Or is it simply walking someone to the counseling center and sitting with them until they're able to be seen? The biggest thing I want to remind everyone is that if someone is suicidal or having suicidal ideation, you never leave them alone. Not for a second, not in your office, not at all. You are with them, you're mindful, and you are thinking about everything that could be possible. If you're in an athletic training facility and you say, let me just make a phone call real quick, and you leave them in the facility, they could easily walk out. They could get access to, say, your scissors to cut their wrist, pills that are left out in cabinets to overdose. Don't let them have access to the means that they may be wanting to use to end their life. And finally, some of the suggestions and components to consider: your risk factors and triggers, exposure to trauma. Make sure you're collaborating. This is going to require you to recognize and refer. We have a role in mental health care, but we have to be collaborative in that care planning. Confidentiality: explore your FERPA guidelines relative to students at your school, relative to the student health clinic or your counseling services on your campus, and being mindful about if a person says, please don't tell anyone, that you're able to be mindful of the laws and regulations of what you can and can't do in that moment. Finally, I want to share 2 examples of policies that were done by students of mine. So I teach a mental and behavioral health class relative to different conditions, and one of the weeks we go over suicide, and they come up with a suicide emergency and crisis policy. So I want to give a shout out to our professional master students, Brittany and Kevin, who I'm sharing their policies. So this is Kevin's that he created for the cheerleading at University of South Carolina. And really takes you through 2 steps. So if they're under crisis, what the crisis may look like, who to contact. If you can't contact that person, then who they would contact, and then identifying the next best person in terms of the chain of command. For this instance, it's our mental health physician on our campus that's in charge of our mental health clinic, and then also making sure that the chain of command involves the medical director or the sports medicine director on your team. Now, if it's a mental health emergency, you can see that it's different. 911 in the event of emergency you can't control. If they're a threat to themselves, consider calling campus police. If you're with the patient and can walk them, there's the counseling address and how to take them there. If you're not with them, consider the hotline. And then also in doing the same thing as a crisis in terms of contacting the athletic trainer, supervisor, and mental health directors. And then finally, the contact information here is provided for our psychiatrist, the emergency assistant, on-campus resources, and then community-based resources like crisis hotlines. All these are great resources to have in a policy to make sure everyone can implement it right away. I also asked the students to create an emergency action plan that could be visually appealing to post in your athletic training facility or office that could be easily implemented. So the one on the left is a yes, I'm not sure, no policy, where it says, is the person showing signs of threatening behavior? So are they in emergency? If it's a yes, then call on campus, call 7911. If you're on campus, call 911. If you're not sure, then call the student health center or the suicide hotline. And if it's no, consider a BIT request, which is a University of South Carolina behavioral intervention team request that says, I'm just worried about someone, I want to get them the help. That creates a non-emergency referral to the student health center. So see what things are available on your campus and create something similar to this where you're able to think about the resources available. And finally, this is a procedural flow chart of thinking about suicide as a catastrophic injury or illness. So being mindful that there's going to be many people involved and stakeholders involved in terms of your medical director, the family of the individual, the athletic director, press releases, sports administrators, and who needs to do what part in contacting those individuals to make sure that everyone is on the same page, that false information does not be shared, and that everyone is informed in making viable decisions relative to the patient's well-being at that time. So that's the end of my presentation. I hope that the information was helpful for you in terms of your planning and dealing with suicide and emergency preparedness for mental health conditions. If you have any questions, feel free to connect with me on Twitter. My Twitter handle is @ZachWinkleman, and my email is winklez@mailbox.sc.edu, and I'll be sharing that with MAATA so you can reach out with any questions or concerns about the presentation. Again, thanks so much for your time, and I appreciate the ability to present to this. Thanks.